Yeah, I know we don't have a lot of time, and I think we've gotten most of our folks into the room now. So I think we'll go ahead and get started. I wanted to start off first with deep thanks to both Corinne and Brianna and Sarah, who helped make this event possible behind the scenes at the LP Project and the Global Health Justice Partnership. And also special thanks to this superb set of panelists who joined us today. We have a really important issue to discuss, and I will both introduce the panel and then moderate what I expect will be a lively discussion. And then we'll reserve some time at the end for Q&A, and we'll just use the Q&A function in Zoom, which I'm sure you're all at this point familiar with. So let me just start by introducing this superb all-star panel we have in front of us. First, we have Fatima Hassan, who is at the Health Justice Initiative, in fact, the founder of it. She's a South African human rights lawyer and social justice activist, and has founded the Health Justice Initiative, which is a public health and law initiative dedicated to addressing the intersection between racial and gender inequality. She has dedicated her professional life to defending and promoting human rights in South Africa, especially in the field of HIV/AIDS, where she worked for the AIDS Law Project and also acted for the Treatment Action Campaign in many of its legal cases. She also worked for the Open Society Foundation, has a BA and an LLB from the University from Wits, and from an LLM from Duke University. We also have Dr. David Kessler, who is the Biden administration's chief science officer for COVID-19 response. Dr. Kessler is also a professor of pediatrics and epidemiology and biostatistics at UCSF School of Medicine. He has held many public and private sector positions of leadership before this moment, including being commissioner of the FDA from 1990 to 1997, the former dean of the Yale Medical School, which is how I got to know him years ago, and more recently, the co-chair of the Biden-Harris Transition COVID-19 Advisory Board from November 2020 to January 2021, and the head of Operation Warp Speed, which was in some sense the predecessor to the role that he has now, which was the US government program to accelerate the development of COVID-19 vaccines and other treatments. Then we have Zen Risby, who works at Public Citizen as a law and policy researcher. He is an expert on pharmaceutical innovation and access to medicines. He's provided technical assistance to state and national governments, coordinated civil society coalitions, and published on intellectual property, access to medicines, and global health. He was a Gruber Fellow at Section 27 in Johannesburg, and has a degree from McMaster University and a JD from Yale Law School, where he graduated from just about 5 years ago. So welcome back, Zen. And then we have last James Krellenstein, who's the co-founder and managing director of strategy and policy at Prep for All. That's an activist think tank that's dedicated to increasing access to life-saving HIV treatments, as well as COVID-19 treatments and vaccines. And he's been an activist since he was a teenager, working on access to antiretrovirals, and has crisscrossed the world of advocacy, working on both antitrust issues, in fact, quite fundamental to a very important lawsuit going on now about antitrust against one of the largest manufacturers of HIV medicines. And he has been, through Prep for All, doing very important work, as have the others before us, on these critical questions of COVID-19 and vaccine access. So I'm going to start us off by offering some background to why we framed the discussion the way we have today, why we want to focus on the question of global vaccine access, and why we're having this event, and the background facts. So let me just share my screen. And start us off. So here's the aim of this panel. There are dramatic gaps globally in access to COVID vaccinations, and I'll try to give a few details about those. But the core question that we want to talk about is, if we want to make it possible to vaccinate 70% of the world by June 2022, which is the goal that the World Health Organization has set out, how much vaccine do we need and how do we get it? That's our aim. So just to set that up, I will run through three quick issues. One, the sort of state of global vaccine inequity as we have it, question about why we want to vaccinate and extend vaccination to the world, and then current initiatives and shortcomings. Global vaccine inequity is, of course, familiar to any of us who are reading the newspapers. And of course, we may have people joining us from around the world who are quite familiar with the day-to-day lived reality of the inequity in access to vaccines. But what we know is that where vaccination is widely available, we have massive health benefits and reductions in disease, hospitalization, and death. But globally, vaccine access is highly inequitable, with coverage ranging from 1% to over 70%, depending largely on a country's wealth. 77% of vaccinations have occurred in high and upper middle income countries, and just 0.5%, according to the latest data, in low income countries. So this will just give you a sort of pictorial version of the inequities in access. This is the state of global vaccination as of January 1, 2021, April 1, 2021, and then October 11th, 2021. As this shows, the inequities are actually quite vast, and it'll shows in particular the regions of the world, and here Africa really stands out, that have really startlingly low levels of vaccination. So this is a prediction from July 2020 that suggests that there are many, many countries that will not have widespread vaccination until the end of 2023. The slide's a little bit dated now, but one of our questions will be what's changed, where we are now, and what we might need to change to get to the goal of much more rapid scale up of vaccination. So why is this a problem? Why vaccinate the world? Obviously, vaccines are life-saving. 3 million people have died globally since the introduction of the Pfizer vaccine. Obviously, vaccines will help further prevent illness, shutdowns, dislocation as well. We have good estimates and modeling estimates that show from the United States that we've had already hundreds of thousands of deaths averted from COVID vaccines, and obviously scaled to the world. We're talking about millions of deaths that could be averted. There's also a domestic story here, right? Why vaccination abroad has benefits in the United States? Well, there's a couple of different dynamics. One, that slowing transmission abroad can protect domestic populations by slowing transmission across borders. But the other really important issue is about the spread of COVID and the implications that has for the emergence of new variants that can either trigger new waves, Delta plus, right, what comes after Delta, and also escape the protection that we have and rely on for the semi-normalcy of life that we've come to in many parts of the United States. That remains vulnerable insofar as COVID is spreading widely abroad. So where are we in terms of current initiatives, and what are their shortcomings? The main global facility to try to get vaccines to particularly low and middle income countries is called COVAX. It's co-led by the WHO and also 2 organizations called Gavi and CEPI. That initiative really has stumbled. It didn't have very high aspirations at the start. So almost 18 months ago, the goal was to get 2 billion doses. And remember, you need 2 doses for most vaccines, right? So 2 billion doses to be distributed by the end of 2021. We're now almost at the end of 2021. So where are we? COVAX has delivered only 319 million doses so far less than 5% of all the vaccines administered globally. Wealthy countries had pledged to donate 785 million doses to COVAX, but just 18% of those doses have actually arrived. Some of the story, as that suggests, is in the lack of delivery of vaccine doses that have been promised to COVAX. And here's a figure that it's been a problem across the developed world, delivering the vaccines that have been promised. The reasons for that are complex. We could talk about vaccine nationalism, concerns about local supply, boosters, for example, but also significant shortages because the producing companies aren't meeting their own targets. This is some data from Prep for All about the difference between production forecasting and what companies have actually produced. And this is going to be quite important because when we get to the question of how much vaccine we need to know how reliable the forecasts are. So had you looked at the forecast a year ago, you might have thought we would be in an okay place today with respect to our global vaccine supply. But in fact, those forecasts have been sort of dramatically underperformed. One sec, one more slide here just to drive that point home. This is data from the analytics company Airfinity, which shows that the Chinese companies have actually generally met the targets they have announced, but that vaccine manufacturers otherwise, and you see towards the bottom of this slide, Moderna and also J&J, which we'll be talking about today, missed their targets by these generally non-Chinese firms missed their 2020 targets by 96% and are missing their 2021 targets by about half. So that's the general picture, right? Obviously, global disparity and very sharp need on multiple grounds, and then a sort of failure of COVAX to really deliver what it had promised, and apparent difficulties that companies have had making their own manufacturing. As we'll get into, there are sort of newer projections that are more optimistic about where the companies say they'll be shortly, and that's one of the things that we're going to try to understand. So let me stop sharing that now and get to our questions and to our panelists. So let me start off with a question for Fatima. So would you begin just by talking to us? I know you're in South Africa now, and what access to the vaccine is like there and also in the rest of the continent, and what that really means practically on the ground.
Thanks, Amy. And yeah, it's just so fantastic to be on this panel with Zain, James, and Dr. Kessler. So first, I think many of you were vaccinated much earlier in the year, and I got my second dose of a Pfizer vaccine at the end of August 2021. I think my mom, who's 75 years, got it, months after Zain and James were vaccinated. So I think that's just an example of what we're dealing with in Africa. We would classify it as a drip feed of supplies. Clearly, from where we're sitting with less than 5% of the continent of Africa fully vaccinated, and mainly because we haven't had sufficient supplies in the last few months, we're looking at two things: a situation of grotesque vaccine apartheid, and grotesque is a word that the WHO DG has used himself, but also a situation where we just don't have time on our side. So time is definitely against us. We have these great publicly funded vaccines, the work that Operation Warp Speed has done, the work that the US government and other governments have done in publicly funding these really, I think, remarkable medical interventions, but they're just not accessible to most of us here on Africa. So when you talk about South Africa and why it's slightly orange on that map, and we'd love to see ourselves, as a dark green, we're looking at about 25% of adults now fully vaccinated, mainly because of a consistent but drip feed supply of Pfizer vaccines. And, I think you all know the situation of Johnson & Johnson, which hasn't really fully delivered on its vaccine promises for South Africa and Africa. So in respect of Johnson & Johnson, we only have about 6 million of the 31 million vaccines promised, while vaccines were actually exported to Europe at the time when we were entering wave 3. The situation in the rest of Africa is much bleaker. Of the 35 countries in the world that has reached at least 5% vaccination coverage, 28 are in Africa, and I think that explains why that map looks so beige and so yellowy. 9 countries in Africa, as of the end of September 2021, have only reached, the so-called 10% target of at least reaching 10% of all people in their countries, and South Africa is one of them. The other countries on that list are so small and tiny that it's hardly something to celebrate, and it's hardly a significant achievement to be able to say at the end of September 2021. We're one of the countries on a continent that has reached at least 10% vaccination coverage. I think the mood, the way in which people in Africa are responding to this is that world leaders have actually let us down. That CEOs of these drug companies are more powerful than a lot of elected leaders around the world. I mean, the efforts that South Africa and India have been pursuing for the past year on the TRIPS waiver, which has mostly been blocked, and it's still being discussed a year later in the middle of a global pandemic. And so just, finally, I think we're at a situation where we've been given a lot of promises. There's been lots of pledges, lots of, some erratic donations, but they are unsustainable. It's never certain what's going to happen in relation to those donations. So unless we expand capacity, and we can talk later in the panel about the hubs that have been set up here and about the fill and finish licenses that have been issued for South Africa, which are actually not addressing the real need. So, basically we're in a situation where something really has got to give. And we look to the US government, and particularly Dr. Kessler, to really take more action against the CEOs of Pfizer, Moderna, and Johnson & Johnson. Because without that kind of political leadership and action, I can guarantee you that Africa is not even going to reach 25%, when we speak about the same situation or the same issue next year. Thanks.
Thanks, Fatima. So this question first question, I guess, after that, that I have is for Zen and for James to help us think through whether current supplies are sufficient. We know there's more being promised in the pipeline, and what kind of assumptions are built into those projections, and also which vaccines should we prioritize and why? So give us the sort of introduction to those questions from your perspective. I don't know which one of you wants to go first.
Ben can go first, of course.
Thanks, James. So thanks, Amy. I would say it is a moment of great uncertainty. Like so much of the pandemic, we are in a moment where we're not really sure what the next path of the pandemic looks like. And as a result, that has placed extraordinary stress on both the supply and the demand, because there is a huge uncertainty, right? So one of the key assumptions that is made on the supply side is that, well, the vaccines that were promised to have been scaled up will actually scale up. And we see sometimes how those promises fall far, far short. If you look at J&J, for example, this is one of the largest pharmaceutical corporations in the world. They promised 1 billion doses by the end of the year. Right now, they're at about 100 million. You look at a company like Novavax, which has been, continually trying to get regulatory authorization, and it's still not clear. And many people pin their hopes on Novavax as being the vaccines for the global south. And that, frankly, still is not the case. And then there's also the case about, even if you do have the supplies, even if you sort of eke out the supply, will there be enough supply such that there is enough donation? Will wealthy governments actually donate the doses they have that have been produced? And we think in order to, obviously they should. But at the same time, we recognize that sharing the pie is simply not enough. You have to make a much, much, much bigger pie. And I also want to kind of separately flag also the demand uncertainty, right? Because we're seeing conversations about boosters, which are challenging and complicated. And we don't know how widely boosters will eventually be indicated. And then finally, I think the kind of scariest possibility, but one that is worth discussing, is simply the assumption that the vaccines will work by the time, or the vaccines will work as effectively as they're working now by the time that they are scaled up. Because that is not a guarantee, right? We hope so, but there is a possibility that as SARS-CoV-2 continues to evolve and continues to change, that eventually leads to changes in how we design the vaccines. And so suddenly you're going to see, once again, the vaccine apartheid with better vaccines offered to better people. And so I think in terms of which vaccines we should prioritize, I think it's about the clinical data, about which vaccines that appear to be the best, the ones we know we can rapidly scale all around the world, and frankly, the ones that can be adapted quickly if needed as well. And so we do need, I think, fundamentally much more mRNA vaccine production capacity.
Yeah, and just to sort of add to what Zen was saying, one of the primary concerns that we're seeing right now is that if we actually look at the portfolio of vaccines that are being allocated to what's called COVAX, right, which is this initiative for actually sharing drugs to lower and middle income countries, a huge portion of those vaccines are from manufacturers who have not yet demonstrated, like Novavax, that they're actually going to be able to get a product either manufactured or actually regulated and approved and ready to go into arms. And that really puts us into a really precarious place about actually, this future that we've seen as we watch 10,000 to 30,000 people die a day, and we watch that, only 300 million people in lower income countries have been fully vaccinated. It's not clear at this point that we actually have a clear path out, even though we talk about the fact that by the end of December of this year, we're probably going to make on the order of 12 billion doses in total. But of that 12 billion doses, 50% of them are going to be from China. They're going to be the Sinopharm or Sinovac candidates. And to go to the point that sort of Zen made earlier, what we are seeing right now is vaccine inequity sort of mutate into a new variant. And that new variant is that we might have actually doses available at the end of December, but we might be giving the least effective doses to the populations who arguably need them most, which are populations in lower income countries. And I think that goes to a concrete and fundamental policy problem that the United States government did. If we look back at what happened in January and February, I think all of us, Zain, myself, everyone on this panel was sort of advocating that the US government really work hard to ramp up production of mRNA vaccines for a couple of reasons. One, as Zen said, they're highly adaptable to new variants. We've already seen with the Beta variant, we've already seen in South Africa that the AZ vaccine is not effective against it. That's already happened. But we also saw that these were incredibly effective and that we could get the manufacturing capacity online in many cases in 6 months or less. And we just didn't do that. And we're sort of in this predicament today where we don't have enough vaccines of the highest quality to give to the people who need it most, I think primarily because of a policy failure. We knew that we could make those vaccines. We knew we could scale up manufacturing, and we sort of chose not to. And I think the question that we need to answer today is, well, where do we go from here, given the fact that it's October and not January or February?
Let me come to David now and Dr. Kessler. So what's your perspective on whether we have the kind of supplies that we need, and on what assumptions, and then also which vaccines we should prioritize?
Enormous thanks for inviting me. Let me just break, the answer to that question down sort of in 3 parts. What have we done? What is the gap we see? And what are next steps, at least short-term next steps? So what we have done, we've shipped, I think as of this morning, out the door, 180 million doses that we have shared, the doses that we bought, and those are out. In addition to that, we have 1 billion doses agreed to for low and low middle income countries from Pfizer that are every reason to believe that they will be delivered certainly no later than the end of 2022. So we have that 1,180 million doses. With regard to the gap, I've spent time talking to our colleagues at USAID. I've also had the privilege of talking to colleagues at COVAX. We understand that according to COVAX, and there's going to be a number of footnotes here, and this may be best case, right? That there is a gap of some 500 to 1 billion doses. And here are the footnotes. That doesn't account for boosts. That's for primary doses. And that assumes that everybody who is slated to deliver delivers. So you have to add to that 500 to 1 billion any companies that have made commitments that do not deliver. But you have that base gap of 500 to 1 billion doses, not accounting for boosts, assuming full delivery, to close, that's the gap through 2022 for low and low middle income countries. Now, what are the next steps? So we have the 1 billion from Pfizer that are committed. We expect that Moderna will step up as a company. We expect, we have asked them, they need to step up as a company and join other companies such as Pfizer and provide the COVAX with doses for the AMC 92 at not-for-profit prices, and at a quantity of substantial doses that will help close that gap. There is very substantial additional capacity at Moderna that has been invested in. And now the question is to get that commitment done at a not-for-profit price and in substantial quantities, because a failure to do that would be unconscionable in my view. I'd be happy to talk about J&J, but let me just close here with saying, one premise and one principle that we have had from the beginning is that it was very important for us in anything we shipped, in anything we ordered, for them to be, and I think we all agree, quality doses. So, we are not, anything that we're involved in to help the world are the same doses that can go in arms of the American people. And we are committed to doing that. We want to close that gap, and we share the urgency that all the panelists have stated today.
Thanks, Dr. Kessler. So there's, I think, maybe a couple of areas of divergence, if I can pull apart those two accounts. Some might be about the level of doses that we need, depending on how optimistic or pessimistic one is about assumptions. Some might be on this time frame. And I think there are other kinds of reactions or differences about maybe the approach that would get us there. So I wanted to go back to James first, perhaps reactions to that, to what you've heard now about both where we are and how we should sort of react to where we are, and then what the next steps might be from your perspective.
I think we are on the sort of general same page that if everything that we have on the slate today that we have committed for actually came through, we would still have probably around a deficit of around 500 million to around 1 billion doses. And it's a little complex to actually get a precise number on that, but it's just, a sort of order of magnitude estimation. That is where we are. But what we do know definitively is that we're not going to get 100% of what we asked for delivered on time. That has been the history of this pandemic from the get-go. And it's just a fundamental nature of where we are in vaccine manufacturing. Vaccines are very difficult to manufacture, as we know. And to assume that we're actually going to see most of them be delivered is just not a reasonable assumption. In fact, if we look at even the projections that we have right now, the vaccine manufacturers are only going to meet 50% of their stated production targets by the end of 2021. So we like to introduce what we call a safety factor into what we're doing in our calculations. We generally assume that when you order 500 million doses, you're probably going to get 250 million doses within that time period that you asked for. So we think generally it's good to model out that you should basically be ordering or assuming that you need double the actual number of doses that you need. But I have to once again emphasize, from what our concern is the extreme precarity of the actual doses that we are relying on for global production, right? We are relying heavily on Novavax, which has not gotten regulatory approval from a single regulatory body across the world. We're relying heavily on getting Johnson & Johnson production online, and actually rapidly online. Johnson & Johnson is slated right now to deliver more doses to COVAX than they have produced at all. They have to make double the doses that they made in the entire history of Johnson & Johnson's vaccine just to get to the COVAX delivery amount. Forget about what they have for the higher income countries. We're relying on companies like Clover Biopharmaceuticals from China, which has not ever made a full-scale vaccine, and we don't know if it's actually going to be FDA approved or approved by any global regulatory agency. So if you take all of that in, we're looking at a place where we're probably on, or more like 1.5 billion doses short, if we just rely on reliable manufacturers. And then, although we talk about boosting in this country in the context of people who have had 2 doses of Pfizer, 2 doses of Moderna, the real thing that we see as the demand for boosting right now is not in the higher income countries, but is in countries like that have gotten a huge amount of the Chinese vaccines, which unfortunately are just not that effective and wane much more rapidly. So we're looking at the possible booster demand, which really is going to be necessary to protect people from death or hospitalization, on the order of another 1 billion doses by the end of 2021. And those are essential doses that we have to get out. So we are looking at really a whole of around 2 billion doses. And once again, if we implement that safety factor, we're looking at we need around 4 billion doses more is what we should be planning on for production capacity.
So James, just to follow up on that, I mean, I think from Dr. Kessler's perspective, Moderna has excess capacity, and so the right way to do this might be to just encourage Moderna to come forward with more doses. Is that your view about how this is best done?
Well, we don't know actually what Moderna's capacity is, quote unquote. And we should be clear that when we talk about Moderna's capacity, what we're really talking about really is Moderna's contract manufacturer's capacity, which is a company called Lonza Group in Switzerland. And we see Moderna not producing that much vaccine doses. I think last week they produced something on the order of 4 million doses per week. we don't have that much transparency in how much more doses Moderna can make and what they actually have directly invested in. One of the proposals that we have made to Dr. Kessler and to other officials in the US government is that the US government should have its own production facility operated by a company like Lonza to actually make Moderna's doses under license. So we have direct transparency, direct control as the US government. We have a contractor operator like the national labs the Department of Energy has, and we could have direct control of this production process and control where those doses go to, still respecting Moderna's IP, paying them some license, but also most importantly, having a way to transfer this technology in the medium to long term to countries around the world to actually teach them how to make their own vaccines. Because I think one thing that we have learned, that I've learned as an American citizen, is that countries outside of the US cannot rely on the United States, unfortunately, to supply them with the vaccines that they need. That's the reality of where we've done. The Chinese scaled up vaccine production amazingly. Unfortunately, they had a pretty bad vaccine. The US government, to be honest, did not make the direct investments after warp speed for domestic production in international production. And we left the rest of the world out to dry, to be honest.
Dr. Kessler.
So
what is your response?
I agree with all of James's calculations. I agree that best case was the 500 million to $1 billion. I certainly understand that there are companies that are not going to deliver, so you have to add to that number. And it's going to be in excess of that billion. Let's focus on the short term and what does it take. I mean, I think we can also talk about longer term solutions. But the most important thing is filling this gap now. My view is we really have three major resources, all of which are quality vaccines, all of which have EUAs, Moderna, Pfizer, and J&J. I have no doubt, unless something unforeseen happens, that Pfizer will deliver. I mean, that has been their track record. Moderna can speak for itself. We've been in very, very intense discussions with Moderna. There is very substantial capacity through 2022 for them to close and in fact even exceed the COVAX gap, and they need to do that. And there are discussions underway with our assistance between Moderna and COVAX. In addition to that, right, and there's very substantial capacity in the billions at Moderna through 2022. I think that J&J has had, there have been shortcomings in that production. They're well known at the emergent facility. Hopefully that facility, it will be dependent on our colleagues at FDA, that facility, the emergent facility gets added to the EUA by the end of the year. And more importantly, we have invested mightily in hundreds of millions of dollars into the Merck J&J partnership. There are doses that are scheduled, I hear, to come off the line beginning in April, right? That should be, that production capacity through 2022 from J&J is also in the billion plus range. Putting together that J&J capacity and that Moderna capacity, and you look at James's gap or my gap in the range, short term through 2022, and I'm happy to talk about further investments because I think we need to do that. There is, if both of those companies step up as we they need to do that, that this gap can be closed, in my opinion.
So I'm looking over at the Q&A, which has gotten very lively here, and just it's back quite relevant to what we're discussing right now, which is some, I think, lots of questions about why, given particularly the US government's investment in Pfizer and Moderna, there isn't sort of stronger action being taken by the US government to require them to share technology and scale up quickly. I'll come to Zen in a minute about the legal avenues that the US government has to do that. But I'm curious, David, if you feel that urgency or your sort of reaction to the basic sort of challenge coming from the questions in the chat here, why not exert more leverage over Moderna and Pfizer, given all of that investment, in order to make them scale up quickly? Because there is this gap, right, that is both about how timely these doses are likely to come in and the number that we have that we can expect.
I'm happy to engage in any of the legal options that you think are available. And the pros and cons of each. Do not underestimate the resolve of the United States government in addressing this issue. I think these companies understand our authorities and understand that we would not be afraid to use them. But the best recourse right now is for them to step up to the plate now, right? And make sure they provide COVAX at not-for-profit prices and substantial doses to close that gap. There is a specific request by the United States government for them to do that, and they understand our authorities.
Zen, I wanted to come to you and then I'll come to Fatima. So Zen, first, if you could, looking at the time also pretty succinctly, talk about what you think are the important powers that the US government has that it isn't using that it should use. And then Fatima, I want to come to you to bring us back to the question of global manufacture and whether or not we need manufacture specifically, which we haven't talked much about yet. And some of the other questions have gotten to, do we need manufacture in Africa and what would need to happen to get that going? So first Zen, and then we'll come to Fatima.
Sure, I'll just share these slides quickly. So I think the primary and most powerful authority is the Defense Production Act. Defense Production Act really is meant and designed for these situations. If you think about it, more than 700,000 Americans have already died from COVID-19. This is an attack on the US. And so it is puzzling why all the authorities of the Defense Production Act had yet to be used. So primarily the Defense Production Act can allow the president to allocate material, services, and facilities. And so you could imagine the US government requiring Moderna to allocate materials. And importantly here, the definition of materials includes technical information. And so from public reporting, it's clear that the US government is asking Moderna and Pfizer to share their technology, but there are actually provisions within the Defense Production Act that could allow the US government to require the companies to share technology as well. There's lots of provisions in the Defense Production Act, including about also requiring companies to accept and prioritize contracts. The second thing I want to get to really quickly is just the contractual rights, because there's been some reporting on this. Within the US government's funding, let's be clear, the US government is the largest funder of coronavirus research and development in the world, right? By far. And so within some of these contracts, we have found that the US government appears to retain some authority over critical information. So this is the Moderna contract. The US government has unlimited rights, that's what the contract says, to data funded under the agreement. There's a lot of redactions, there's a lot of reason to be cautious about the scope of the claims, but it's clear that there is some information that the US government has unlimited rights to. The same contract also says very clearly that the US government has access to Moderna's FDA submissions, which include chemistry, manufacturing, and controls data, which is basically a part of the vaccine recipe. The US government also has provisions and access to other manufacturing information. So there's two questions raised by this. What is actually in the US government's hands right now, which is pretty clear that it's significant vaccine information. And then under the contract, separate from DPA, what can the US government share? And then finally, the third kind of provision is really points to the central role of the US government in developing these vaccines, right? Nearly all the leading candidates rely on US government-owned technology. This is the stabilized spike protein. And as of March this year, the New York Times reported that only Pfizer-BioNTech actually had permission from the US government to use this technology. And so if that is still the case, then most of the companies are likely still infringing on US government IP. And so the US government could work out a grand bargain in which it requires the companies to share technology in exchange for permission to use its own technology.
In fact, Fatima, can I come back to Dr. Kessler for a minute to just get his reaction to those before we move on to the African manufacturing question? So David, your reactions to that?
Professor Kapzynski, I don't want to play lawyer. I leave that to you and Zain and others. But let me see if I can just clarify a few things that may be helpful. I have read your analysis, Zen's analysis. I appreciate them very much. Again, just personally, I would agree that certainly DPA probably is the strongest authority, and that does give the president the authority to allocate doses. Right. I mean, we can discuss what else it does, but it clearly allows the president to allocate doses, and certainly with regard to foreign infrastructure, and vaccines are certainly covered. With regard to the contractual issues, I think there's been some misunderstanding there. And let me just see if I can, again, I'll leave it to the lawyers, but to clarify, there is in fact 2 contracts. There may be others, but there's an R&D contract and there is a procurement contract. Under the procurement contract with Moderna, that did not require the company to deliver any of that information. And as I understand, under the R&D contract, while those items were can be requested by the contracting officer, they were in fact designated as limited data rights, so they could not be shared even for under government rights. Again, I don't want to get into the legal. Suffice it to say that, and I have asked this question of my colleagues, but as I understand it, I mean, to date, best as I understand it, the government is not in possession of the know-how necessary or the recipe, for example, for the mRNA vaccine. So I just want to clarify, that's what I know. Again, others can add, but I think there is substantial authority, I would agree, under the DPA, and there may be authorities under these others. I just wanted to clarify. Thank you.
And did you have any quick follow-up on that, or should we move on to the question of African manufacture? Okay, so Fatima, talk to us about whether you think it's important to have manufacturing happening locally, and why, I think particularly with respect to the mRNA vaccines, that isn't happening, and what would need to be done to make it happen.
So, I mean, just having listened to this, this is so disheartening, because I think, obviously, David, you're in the hot seat, and there's a good reason for that. But the current model that we have of not scaling up manufacturing, and whether we use African hubs or Latin American hubs or Asian hubs, really at this point, or even US hubs, is immaterial, because people literally are going to get more sick and die. I mean, it's an untenable situation to be on a continent where less than 5% of people are fully vaccinated, because we literally on the ground waiting for supplies. Despite all the promises and projections and forecasts and pledges, the supplies are actually not here, right? And so I think that's a real problem. And the reason for that is knowledge hoarding. And I just can't believe that President Biden can't march in. I mean, these are companies with safe and effective vaccines, which we participated in clinical trials so that you could benefit from the scientific knowledge. I mean, these trials were also conducted in parts of Africa, including in South Africa and parts of Latin America as well. And Biden could march in and could compel the transfer of that technology. And the fact that we're still in October 2021 talking about voluntary action of the CEOs of these pharmaceutical companies who are not even elected leaders, for me, is really, really distressing, because we've been through this before in the HIV/AIDS crisis. And if we're going to rely on their voluntary action and their cooperation, then what we've seen from this past year is that that's not going to materialize, and it may take many years. And if we have to repeat these vaccination programs, which seems likely we're going to have to, because I'm not really sure a booster shot is a booster shot. It's actually probably a recurring annual vaccination program, which is likely to also happen in South Africa. We're going to need the same amount of supplies going on for maybe even 2 to 3 years. That's according to Tom Friedman. So let's just talk about Moderna. Not a single low-income country it has delivered to. It has not agreed to participate voluntarily. We've waited the whole year to participate in the mRNA WHO hub that's been set up in South Africa down the road from me. It's sitting there, it's empty. We now have to copy and replicate that technology, and it may take us 3 years. So that's an untenable situation. It refuses to submit its dossier in South Africa and refuses to supply many African countries. It decides which countries it actually wants to support. We need the Biden administration to step in there. Pfizer has not agreed to participate in the WHO mRNA hub that has been set up in South Africa either. It has given BioVac a fill and finish license, and that capacity of maybe 100 million doses, which would only cover 50 million people of a population on a continent of 1.3 billion people, that may only come online in 2022. So those fill and finish licenses are not sustainable either, because it relies on the voluntary cooperation and participation of these companies. Nobody is compelling them to do anything more than to just give one small fill and finish license to one country in Africa to basically keep activists quiet. Not a sustainable solution either. The same thing with Johnson & Johnson. And I mean, you've talked about the situation with Emergent, which had a direct impact on the ability of South Africa and the rest of Africa to start their vaccination programs, because we were all waiting for supplies from the one single fill and finish license for the whole continent via Aspen to Johnson & Johnson. It refuses to give a full manufacturing license. It refuses to license multiple manufacturers. There are at least 5 companies in Africa that could take the mRNA technology as well as the J&J vaccine and actually scale up manufacturing, and they are being refused. About 100 companies applied to the WHO expression of interest or the invitation to set up mRNA hubs, but the companies are playing God. The CEOs are deciding which companies get a fill and finish license, for what volumes, for what prices. We had to do a lot of work to expose Johnson & Johnson's extraction of an export concession where millions of vaccines were sent to Europe instead of to Africa. J&J has not delivered more than 10 million of a 220 million contract, which it signed in March 2021 for Africa. It's only given us 6 million of 31 million contracts. So we can talk about voluntary cooperation and these licenses, and yes, they've been signed, but they're not serving our needs. They're not serving our purposes. So if we are going to turn the tide, if we're going to talk about real political leadership, there are 3 companies that are headquartered in the US. The Biden administration has to march in. And we can do that by sharing technology with available existing capacity or invest in additional capacity. And like I said, people are getting sick and dying. Whether these hubs are in the US, whether they're in Latin America or Africa, I think is immaterial. The point is we need to ramp up global manufacturing capacity to actually serve the rest of the world, particularly because we're now having the conversations about booster shots. Thanks, Amy.
Dr. Kessler, back to you.
Well, Amy, maybe, again, I don't want to delve on the technicalities of which authorities are best here. I mean, you can probably take the next hour and you and Zen can go through. I think there is no doubt that we have a short-term problem that needs to be addressed. And I think that Moderna and J&J can and must step in on that short-term issue. I think there is the longer-term solutions that I would think will take several years, but I think that we need to start now and address. I do believe, and I'm a strong proponent, and I think some of the comments that Fatima has just made emphasize the importance of building pharmaceutical mRNA capacity on the African continent. The reality is, and I've seen it just from the United States perspective, when you have a manufacturing plant in your country or on your continent that is making vaccines, it's much easier to make an argument that you don't have to stand in line behind everyone else in the world, right? So getting pharmaceutical manufacturing capability in those countries that have less access is absolutely important. And we expect that companies like Moderna will enter into arrangements with local pharmaceutical companies on the African continent to do that. We think it is absolutely critical. Now, I do point out, and you can all help me, because my sense is it's been 3 decades. We don't have a great track record, of doing this. This is very hard. I mean, if you look at HIV drugs, you can all help me. The generic drugs tended to be made in India. We've not built capacity, so I'm not saying this is, there's not a lot of work ahead, but I think it is absolutely essential that certainly to begin now, recognizing it will take several years to build capacity on the African continent. And we are committed to seeing that happens.
Can I just have add a quick interjection here? David, let's just get a little real here. I mean, by the end of this conversation, right, this hour-long panel or an hour and a half, 900 people will have died from COVID-19, right? And globally, over 10,000 people every day are dying right now. And we know basically almost 100% of those deaths are completely preventable if there was vaccine access. And the thing that scares me about this conversation, just to be frank, is building new capacity. We can do it quickly. We've done it with mRNA, it takes 6 months, but 6 months is still 6 months. And we've been talking about this for longer than 6 months at this point. We've been talking about this since December and January and February. We can't just rely on Moderna and say, well, is Moderna actually committing to that production capacity? I haven't seen a firm commitment from the company that they are actually building to the capacity we need them to. And at this point, we can't take their word for it. We need to guarantee that there will be capacity when we need it. And we haven't been doing that for 9 months, and thousands of people are dying every day as a result. And it's threatening our national security as well.
Right. So I think it's just very important that, again, we're flipping back and forth. I agree with everything you said, but I think we do have to just put in 2 major categories and recognize that there's getting doses now, right, over the next 6 to 12 months, right? There is that capacity. There is enormous capacity, right, at Emergent and Merck and J&J. There is very substantial capacity at Merck, right? Those companies have to step up to the plate and deliver doses now over the next 6 to 12 months. They have that capacity to do that. Then there is the question of building further capacity. And I think we could recognize that that's going to take longer. That's my only point, James.
Let me come to Zen, who's helpfully raised his hand.
Thanks, Amy. So a few points there. I think one, it's true that the US government should have, it's true that the companies should have been allocating their doses to the low and middle income countries at a reasonable price. And it's true that this should have been done months ago, right? It's not even the bare minimum, right? This is like something that is so obvious that it baffles me that it wasn't done on day 1 of the Biden administration's agenda, right? Like, we need access for global vaccines. We need to end the pandemic. So that is, like, I think all of us agree that certainly needs to be done. I think what we're also talking about is that we need much more capacity because we just have so much uncertainty about the course of the pandemic. We have seen how the pandemic continues and continues and continues without access to vaccines. And we have frankly seen from developing countries themselves huge demands placed, right? You have, for example, the South African government, who has been a real champion working with the World Health Organization, trying to set up this mRNA hub, right? And so right now, at this moment, down the street, actually from Fatima, there are manufacturers, there are scientists that are working to reproduce the Moderna COVID-19 vaccine. And so if they're going to spend months to try and replicate and experiment and try and get to the knowledge that Moderna already has, and so we're going to let them waste that time in a pandemic, it is unconscionable that the US government is not doing more to support those hubs and to make the requisite investments. We've seen actually some positive steps from the Biden administration. Sure, I want to acknowledge those. We have seen, for example, even Congress allocating $2 billion for global and domestic vaccine manufacturing, through the ENC committee. Now we need the Biden administration to step up, because at the end of the day, look, James, me, Fatima, Amy, we're not sitting across from the heads of Moderna and Pfizer. We can't tell them what to do. COVAX can't tell them what to do. The head of the World Health Organization can't tell them what to do. There is a singular, unique power that the US government has, and the US government has alone. This is the moment. And the question is, will the Biden administration rise to the occasion?
We've already told them what they have to do.
Fatima?
Yeah, they're not going to do it, right? So I think we all know what's coming down the line, because I think Zain is right. I have no power over the CEOs of Moderna, Pfizer, Johnson & Johnson. In fact, when we write letters to them, they don't even have the decency to respond. We handed over a petition to Johnson & Johnson, and they took it through a security gate. I mean, they didn't have the decency to even come out in person to accept a memorandum from us. So, this is the kind of power we're dealing with when it comes to pharmaceutical companies. So I just want to say three things about Moderna, and to really, really urge Dr. Kessler to actually get to the point of taking more firmer action against Moderna. And I hear you where you're saying that, you've given them an ultimatum, and hopefully they'll see the light. Moderna CEO is about to be celebrated with an award, so to the Pfizer CEO, and we will make our opposition to that known. But they've now said in October 2021, months into this pandemic, after a lot of criticism and after the protests that James and a number of other activists led outside the CEO of Moderna's house, that they will set up a plant in Africa. Where in Africa, the large continent, why not in the mRNA hub is all questions that are not being answered. So a great PR statement that they're going to commit to a hub, that they're going to invest in manufacturing capacity in Africa, but no details, right? They are registering patents in South Africa right now, while they have said that they're not going to enforce patents in this pandemic. So clearly there's a game plan for Moderna. They know exactly what they're doing. They've looked at the different scenarios, and they're basically going to define and decide themselves when this pandemic is over, so that they can start enforcing the patents and still extract as much, I believe, profit and also control out of this pandemic, so that there isn't this genuine voluntary cooperation to actually share knowledge in the middle of a pandemic. And so for me, really, our assessment is that Ben Saul, Albert Bourla, the head of Johnson & Johnson, these CEOs are actually more powerful than anybody else in the world. They're more powerful than the Pope, the Vatican, who's called for vaccine equity. They're more powerful than the DG of the WHO. And frankly, at the moment, I mean, definitely more powerful than Cyril Ramaphosa, because for a whole year, we haven't been able to make any headway on the TRIPS waiver. And frankly, at the moment, they're acting more powerful than President Biden. And the reason why, it's unusual for an activist like me to say that actually President Biden can exercise more power and that he does have a lot of sway is because when you made the decision to partially support the TRIPS waiver, even though it was just on vaccines, it shifted. It changed the terrain in which we were trying to argue that intellectual property has become a key barrier. It forced other countries to come on the side of asking for the waiver. So I don't think that we can underestimate the amount of power and amount of influence the Biden administration has. If there's anybody who can convince the CEO of Moderna, Pfizer, and Johnson & Johnson to do things differently, and not even just the right thing, they'll never do the right thing, but to do things differently, then I think it's the Biden administration, because every other elected leader, the 100 countries that are supporting the TRIPS waiver haven't been able to do that.
David, we have put you on the hot seat here. I want to make sure you feel like you have an opportunity to respond before going to James and some of the questions in the queue.
Please go to James.
Okay, let's go to James.
I'm just going to end it. I know we have to get to the Q&A, but I think, David, Dr. Kessler, you need to understand, we've talked enough, you need to understand why everyone is so skeptical about Moderna and Pfizer rising to the occasion. The math that needed to be done to figure out what the dose demand was globally was trivial. It was literally multiplication. I mean, both Zain and I think within a couple of weeks of each other had our own ideas back in December and January about what the dosing was. And we communicated those to the Biden administration as hard as we could. We wrote op-eds in the New York Times. This was not complicated to figure out. This is a global pandemic. We need to be building this capacity now. And it's now October. And we're now being told, well, they didn't do it then when they knew what the capacity was, what the demand was. And now we're being told, well, people around the world need to wait, and many of them die while we're waiting and trusting that Moderna is just building this capacity. I don't understand why that's a reasonable position to take after what we've already learned. You know, fool me once, shame on them, but fool me twice. Shame on us for not demanding something different. And I don't understand why this administration is not asking, but demanding they do this.
So let's just make sure we agree on the math, right? We started off with, you know, best case 500 to 1 billion. We agree that there needs to be that safety factor. No one, I mean, my estimation and understanding is Moderna has a capacity for 1 billion extra doses in the short term. I see the same thing for J&J. Beyond that, I think that we are strongly supportive not only of the TRIPS waiver, we are strongly supportive of building capacity, local capacity, working with the WHO. There's investment in the Quad, substantially in India. There's investment, as you know, in South Africa and Aspen. But I agree that that will take longer, right? So there's really two streams of work, right? We have to close the COVAX gap and close it now so that these doses can get in arms emergently.
I'm going to try to pull a few themes from the Q&A that haven't yet been discussed because a lot has been discussed. So one is, and I guess I'll bring it back to David, you know, there's a lot of conversation in the Q&A about the fact that the US government has funded, particularly Moderna, but in fact, all of the companies that we're talking about in various ways. Does that make a difference to the sort of equities of the situation here? And I guess I want to fold into that a second question. What do you think are the reasons that the companies aren't sharing these technologies and aren't sharing the recipes, given that they themselves seem to be running up against their own limitations in terms of vaccines?
So let's just put on the record and make sure everyone understands what we have funded, because it is very substantial, and I do think it makes a difference. Right? I believe that the total U.S. R&D investment from both BARDA and NIH is $1.7 billion. In addition to that, there is patent intellectual property rights, non-exclusive rights that the NIH has made available to all the companies that Moderna has also used. And I think there's strong arguments that this vaccine was, certainly efforts from both NIH and Moderna went into this. In addition to that, we have procured over $8 billion of doses. So Moderna has some $10 billion of taxpayer money. While Moderna does deserve substantial credit, the United States government has played a very substantial role in making Moderna the company it is. And I think that does up the ante on Moderna, and we have said so. Again, not to get into some of the technicalities, just because you have a patent, I mean, NIH can collect money, that doesn't necessarily translate into tech transfer, et cetera. I know those are technicalities, but they are real. But to your major question of why they have not, publicly, I mean, Pfizer is just opposed. It will not, it is part of the ethos of that company. It is what it is. We can challenge that. I think Moderna will say that they are happy to tech transfer if there is real capability, but they will point to emergent and say You can't even tech transfer in the United States. I mean, it is hard to do. Look, no one. Let's not anyone kid each other. At the end of the day, this know-how is an asset to these companies that they are reluctant to give up. Saying that, I think there is a way to build with Moderna and its partners such as Lonza and its fill-finish partners significant capacity on continents like Africa, and we expect them to do so.
So I see another, I guess, series of questions also here about whether or not the short-term strategy is going to meet the long-term needs. There's a couple of questions about whether or not building vaccine capacity now, particularly mRNA vaccine capacity, is critical. So I think your point, David, was sort of separating the short term and the long term, but whether or not that's in fact viable is, I think, what some of the questions are pointing to. Don't we need to build capacity in the short term to have the kind of supplies that we need, perhaps not even just for COVID, right? But opening the lens to think about the fact that mRNA production may be important for other kinds of global health emergencies. Don't we need supplies and in fact, public manufacturing capacity now to have the kind of health security in the longer run that we want?
I agree with that fully. I just because I was saying they were in two buckets, I wasn't arguing at all that the building capacity now should be delayed. All I'm saying is everyone knows that if we even with the most urgent intentions on that, building that capacity is going to take time and it's going to go past the immediate needs. That's the only reason I was separated.
I see that my colleague Greg, who is in the Q&A, has a question here, and because we're colleagues, I have to let him ask it here. And I'm just gonna, I can't emulate the Greg Gonzalez voice, but I'll do my best. So to be direct, I haven't heard Dr. Kessler explicitly say what he and the administration will do to fill the current access gap. We hear the companies have capacity, the administration's asked them to make more doses, but the light touch isn't working. I'm sure you're talking to the companies, but frankly, you're getting strung along after months of telling us they'll come through. They haven't. What happens now? Details, please.
Amy, you know me well. I mean, I take the compliment that anyone thinks I could do anything with a light touch. This has been anything but light touch, let me assure you.
So I want to, I guess, give the other panelists a chance to also jump back in here, because we've been back and forth going at it here with David for a little while now. Does anybody else want to jump in with reaction to what we've had so far, or where the conversation ought to go next? Just have 5 more minutes, so.
Yeah, just the short thing about production capacity is, look, the world had 0 mRNA production capacity in February of 2020. And we've seen all around the world, in the EU and the US, wherever we tried to retrofit, we were able to get that capacity online in 6 months. In March of this year, the Congress allocated $16 billion to the administration that could have been used to build up capacity. And had they actually started doing that in March, as many of us had been calling for, including Zain and myself, we would see that capacity coming online right now. And we wouldn't be in this capacity hold right now. We would have a way to do technology transfer globally that the US government controlled. And we made a decision not to do that. And that is why we are in this predicament today. It was not a scientific failure. It was not an engineering failure. It was a political and policy failure. And I think all of us need to admit that at this point, the COVID crisis is no longer a scientific crisis. It is no longer a biomedical crisis. It is a political crisis. And that's why 10,000 people will die today.
Zen, and then Fatima.
Yeah, I want to thank Dr. David Kessler for joining us and speaking with us. You know, we of course appreciate the work that Biden administration has done so far, even while recognizing the significant gaps that are there that need to be addressed to fully end the pandemic as rapidly as possible, as quickly as possible, and to, frankly, to build back better, right? So I think a few points. I want to make sure that we don't let the companies off the hook here. Like, of course, Moderna and Pfizer have behaved in the most egregious of ways and have monopolized knowledge and technology that could help others make vaccines. Like, that is just, that should not need to be stated, but I want to make sure that I do state it. At the same time, I think sometimes the discussion is framed around, well, what can the US government get the companies to do? But there are steps that the US government can take unilaterally, right? There are steps the US government has. So we've talked a lot about the DPA. We've talked about some of the information the US government may have or may not have with respect to mRNA manufacturing. And we've talked a little bit about the funding as well, right? And so I would conclude by saying what we really need is leadership, right? We need the US government to take charge. This pandemic has already gone long enough. And if it's true that Pfizer ends up delivering doses, in November 2022, I don't want to live in a world that continues with this pandemic fog for another 18 months, for another 11 months, right? Like, that's a problem. And so I would really like to conclude by saying there are discrete, tangible steps that the US government can still take now that could make a huge difference. And let me just give one very small example, which I think is partly a little funny too. But like, I read a lot of vaccine contracts, and in one of the vaccine contracts, I found that Pfizer had included its manufacturing specifications, and those contracts were publicly available. And so we pointed to these manufacturing specifications, and because there's such intense secrecy about how to make mRNA vaccines, even those 12 pages of manufacturing specifications apparently helped mRNA manufacturers around the world. And so what I'm trying to say here is that there is a spectrum of action, and time, frankly, is running out.
Fatima? So, yeah, I almost fell off my chair when I heard about the $1.7 billion. I thought it was less. And I think that tells us that we're going to have to do this ourselves again. So forward to activism against Moderna for the next few weeks and months, because it was funded by US public money and taxpayers. Because if we're going to rely on government and if we're going to rely on the Moderna CEO and the chairperson of its board to do the right thing, they're clearly not going to. So I think we're stuck. And I think we're going to have to revive the HIV/AIDS activism of 20 years ago, because we're not going to get a compulsory license against Moderna. That will be dragged out. It's almost impossible. We're not going to get the waiver anytime soon. So basically, I just feel like we're stuck. And I think we're stuck because Moderna wants to exercise an enormous amount of control, is really acting in a very greedy way, and wants to make a lot of profit. Professor Yami and Kamran Abbas and myself had argued in the British Medical Journal that this is a crime against humanity. So I think in the short term, our activism against Moderna has to, basically increase. And we've got to force that shift and change, like we did with HIV/AIDS, for them to issue multiple licenses to multiple manufacturers. And then later we will have to make sure that we hold them all to account for all the illness and death that has taken place in the last year.
That's one final, I guess, thing, and then we have to wrap up. Want to sort of wonder, where are we going to be in a year from now? Are we going to be having very different discussion? Is the world going to be in a really different place? Are we going to be in a similar place? And I guess to come back to you, David, following all the chatter in the chat, you've said you haven't used a light touch, and I wonder, are you willing to say how heavy a touch are you willing to use? If we're in the same place 3 months from now, what more are you willing to do?
We can't wait.
Yeah.
We can't. We don't have months to wait. I think that we have called the question. We have met. I'll say it here. We've met with the members of the board of Moderna, not just the CEO. We met with the chair of Moderna, members of the board, in the recent days. They understand what we expect to happen with regard to specifically answering, the question. The United States government has not made a decision yet on, what it would do under every, depending on what the answer is, but we are awaiting an answer. And again, I'm not going to, I can't sit and have those discussions in public here. But I can assure you there is full resolve on everyone in the administration to bringing doses to low and low middle income countries as soon as possible. I am concerned that, long term, I mean, correct me if I'm wrong on the epidemiology, we know these vaccines are only, 50, 70% protective against symptomatic disease. They are very protective against, hospitalization and death, and that's critically important. But if you look at the uptake of vaccine, if that's only 70% and vaccine efficacy against symptomatic disease is 70%, I mean, there's still a lot of places this virus can go, even in the United States, right? But no doubt that the most important thing is to prevent death and hospitalization around the world. And that's going to take, I would agree with James, several billions of doses in the short term.
Anyone else want to remark on the last question about sort of where you expect we'll be in a year from now? And any other closing remarks?
I'll just say that depends on the decisions made now.
I think we're all playing a very dangerous game of dice right now, because things could continue on and the status quo, and we just are killing a bunch of people every day. But we could really get into a very serious problem, even domestically. I mean, not saying that isn't a serious problem, but I think how we are in this place where the clearest, forget about even the humanitarian issues for 1 second, which we shouldn't do, but this is the biggest national security threat the United States faces and has faced my entire life, and probably in decades and decades. And the US government's entire response has been, well, we'll ask Moderna what they can do. We'll ask Pfizer what they do. We'll write them checks, but we won't demand them of anything. And that has allowed a status quo that is putting us all at risk. It's killing tens of thousands of people globally, and it's putting the United States economy and the United States public health at risk as well, because there's a possibility that we get a variant that defeats the existing vaccines. And that is a product of the failure of this administration to have scaled up manufacturing 9 months ago, when they could have, and when we could have had the products out now. And we didn't hear from Dr. Kessler, with all due respect, any concrete actions that we were going to take now. And I worry that we're just going to continue on the status quo for the next couple of months, and the bodies are going to keep on piling up, and the threat is going to keep on growing.
Fatima, unless you have something you want to interject, I think we've sort of run up against our time. So I want to thank all of you for joining us. And, public service isn't easy. We know that, David, and we appreciate you doing it. And appreciate all of you for the public service, in fact, that you're engaged in on this incredibly important issue. I hope we're not back here in 6 months to a year. And I thank you all for the conversation. It's really important, urgent conversation we've been able to have, and look forward to continuing to work on these issues. So thank you, everybody. Much appreciated.